Down here, things only get better with time. It's why we've perfected the art of the scenic route, and why we also love a game that takes all day to play. It's why we know that when we welcome old friends again, everything that's great here will be even better. 'Cause whether it's a long walk, a long lunch, or a long-awaited hello, there's nothing like Australia.
Hello, Mr. Saurabh. We are live now, so you can speak.
Hi, good morning, everyone.
Good afternoon, Saurabh.
Hi, good afternoon, Roland. Good afternoon, everyone. Good afternoon, Anshul. Good afternoon, Dr. Ahmed.
Afternoon.
So, welcome everyone to this session that we have today on health tech shaping the future. The topic for today is readiness of the healthcare ecosystem towards adoption of health tech, and we'll look at specific components within that related to the readiness of doctors towards adoption of virtual healthcare and medtech. We'll also look at the increasing patient and consumer awareness towards new age medical technologies, and how do you really strike a balance between cost effectiveness and medical efficacy. I have an elite set of panelists with me, and what we'll do is initially we'll have a quick round of introduction of the panelists. We are privileged to have with us an elite set of on the panel. We have Dr. Darees Ahmed. Dr. Ahmed is a medical doctor turned bureaucrat who have joined the IAS in 2005. Dr. Ahmed is presently the Executive Director of Guidance Tamil Nadu. He was also honored by Prime Minister for Excellence in Public Administration for the year 2012-13, and he has served as Collector in Subdivision of Shivaganga District, Additional Collector in Madurai, and Joint Commissioner for Chennai, as well as Deputy Commissioner for Chennai Corporation. Hi. I believe we have Ms. Margaret as well with us. Hi, Margaret.
Yes,
Thank you, everyone. Forgive me. The link that was provided to me took me to the FinTech section rather than the Healthtech. I do apologise. My deepest apologies. Where would you like me just to introduce the session, or have you already done that, Surab, while you were waiting? Sorry, you're on mute, I think, Saurabh.
Yeah, please go ahead. Would be good to have the session introduction, and we can go into the introduction of the panelists.
Okay. Once again, apologies, everybody. Look, welcome. Good afternoon to everyone in Australia. Good morning to everyone in India. And welcome to this exciting session titled The Readiness of the Healthcare Ecosystem Towards Adoption of Health Tech. Just a little bit of background information. The Indian medtech market is valued at US $10 billion, is expected to grow by 15 to 20% by 2025. Recent developments in the sector include healthcare aggregators to collect health data, online pharmacies and online consultation platforms. Indeed, all over the world, we are seeing these types of initiatives as universal healthcare systems shift to more community-based ambulatory care, which is enabled digitally. So it's a very exciting and dynamic space to be in. The government of India has initiated policies to realise the full potential of the sector, allowing 100% FDI in developing the quality of medical devices and infrastructure facilities, and things like setting up bio-incubators and technology entrepreneurship parks. And in fact, we're already seeing some very exciting collaborations between India and Australia in this sector. One is between the Andhra Pradesh MedTech Zone and the University of Wollongong. They've collaborated for 3D printing of medical devices. And the George Institute of Global Health in Sydney is partnering with medtech startups in the early value chain of Indian medical devices in that sector. So Australian strength in medical innovation can be harnessed by the Indian healthcare system as we collaborate to support the country's growing population. But this session is actually going to drill down into some of the practical aspects of health tech implementation, because it all sounds very grand, but actually implementing it can be very, very challenging indeed. There's three key areas the panelists will be focusing on today. One is the readiness and mindset shift of doctors towards adoption of virtual healthcare and medtech. And I promise you, as someone who's worked in the health sector for 40 years, that is no simple feat. It's a bit like the legal sector. Just bogged down in paper and manual process, and can be very old-fashioned in many ways. So making that shift, getting the medical practitioners to shift, is going to be discussed today. Of course, very important is also increasing patient and consumer awareness towards new age medical technologies, because we have to bring consumers on this journey with us. And then the third, and perhaps some would argue the most important area the panel will discuss today, is that as health systems mature, they consume a considerable amount of any country's GDP. However, it must always be remembered that while demand for health is infinite, it is an unfortunate truth that national health budgets are not. So striking a healthy balance between cost effectiveness and medical efficacy of the health technology ecosystem is critical. And that doesn't matter whether the payer model is a public payer or multiple private payers or a blended payment system like we have in Australia. This is a critical component of the viability and sustainability of health systems. So the panel will be discussing how to achieve this. It's always a very fine balance, but you're going to hear about that today. A couple of housekeeping points before I introduce the moderator, who I think you've already met a little, and hand over. Housekeeping is in order to reduce the background noise, all the microphones will be muted during the webinar, apart from the person speaking. At the end of the session, the panel will be taking questions. You can use the questions section on the right-hand side to ask questions. Please also note that this webinar is being recorded, and the recorded version of the webinar, including all the audio and visual elements, will be made available to all delegates and participants. And the session is also being streamed live on the Indo-Australian Chamber of Commerce YouTube channel. So let me now introduce your esteemed moderator, Mr. Surab Ranadev, Associate Director of KPMG. Surab has more than 12 years of advisory experience and has worked with diverse clients on engagements involving entry strategy development, feasibility assessment, performance improvement and trade development. Within the healthcare space, he has assisted large hospital chains with their expansion plans. He has helped global multinationals evaluate investment opportunities in India and worked with private equity venture capital funds to evaluate the Indian startup space for investment options. He also worked very closely with Ambassador Anil Wadhwa in developing the Australia Economic Strategy, which outlines India's aspirations for engagement with Australia. And if you haven't already read that, I commend it to you. As part of the strategy development process, Surab interacted with several health tech companies and government stakeholders in both countries. And I know that he's going to share some very interesting insights with you today in the opportunities that exist in this space. So without further ado, I will hand you over now to Mr. Surab Ranadev, and I hope you enjoy the rest of the session. Thank you very much.
Thank you, Margaret. Such an eloquent introduction for the topic. I think there is no better person to set the context on a healthcare topic than Margaret, because she, anyone who knows her would tell you that she has seen the developments in the healthcare ecosystem in both countries quite closely, and she has been involved in this space for several years, and the right person to set this context for the session. Allow me to introduce the panel, and we are privileged to have an elite set of panel today. We have the right set of people from the government side, from the insurance space, as well as the startup ecosystem. So you're going to hear a very interesting views coming from diverse strata of the ecosystem within the healthcare space, both in India as well as Australia. Our first panelist, we are privileged to have Dr. Daraiz Ahmed. He's a medical doctor turned bureaucrat who joined IAS in 2005. He's presently the Executive Director of Guidance Tamil Nadu, the Tamil Nadu Industrial Guidance and Export Promotion Bureau. He was honored by Prime Minister for his excellence in public administration in the year 2012-13. He has served in several positions as sub-collector in Devkotia subdivision of Shivganga district, additional collector in Madurai, Joint Commissioner in Chennai North Division, thereafter Deputy Commissioner Works for Chennai Corporation. In 2011, he became the District Collector of Perambalur District, and he has taken a number of initiatives to develop the district, which had been facing a low and declining per capita income. Later, he also served as the Mission Director for Tamil Nadu State Rural Health Mission for the Government of India, and the Indian government nominated him to undergo several trainings on public policy. He was awarded the Indian Prime Minister's Award for Excellence in Public Administration for the year 2012-13, presented by Prime Minister Narendra Modi, for his work in combating female infanticide and improving sex ratio at birth. Again, always recognized as a fearless and fair officer by the newspapers, the Telegraph, for his recruitment for government posts. And he was also shortlisted for the award by Election Commission for the best practices in conducting of the parliamentary elections 2014. Really honored and privileged to have you, Dr. Ahmed, on the panel today. The next panelist that we have, Mr. Anshul Dayal. He's the co-founder and CEO of Neuromersive, Neuromorphic is a Sydney-based medtech startup revolutionizing brain rehabilitation therapy using virtual reality. He has successfully led Neuromorphic through leading accelerators in Australia, including Murudi, Cicada MedLab, MedTech Actuator, and secured close to $2 million in seed and grant funding. So he's really going to give you insights into the entire startup ecosystem, as well as what's the what are the inputs into really working with leading institutions in the healthcare space. In the short time since co-founding Neuromorphic, Anshul has instigated key strategic and commercial partnerships for the company with the University of Newcastle, Neuromoves, Taipei Medical University Hospital, Taiwan, Narayana Health in Bangalore, India, as well as Kokilaben Ambani Hospital in Mumbai, and also with Facebook and Oculus. Anshul is regularly featured at industry-leading startups, medtech, and emerging technology events, and recently also served as a consultant with KPMG Australia, helping its client with strategy development and execution of virtual and augmented reality in health and enterprise use cases. So you are going to hear a very interesting set of ideas coming from Anshul in terms of what are the various ways that you can interact with institutions, both large and small, across the healthcare ecosystem. The third panelist that we have is Mr. Craig Rowlands, Senior Executive Information Management at Medibank. Craig's role at Medibank has been to provide thought leadership aligned with expertise in delivering pragmatic business-focused information management solutions while leading improvements in the data landscape. He has an extensive background in data and analytics, commencing in the UK until he moved to Australia in 2011. While in the UK, Craig worked for blue chip banking and finance industry leaders such as Barclays, First Direct, GE, HBOS. His first role in Australia was at the ANZ Bank as head of decision systems. Thereafter, Craig joined Medibank from Latitude Financial Services, which is formerly GE, as head data management, where he led large team responsible for data strategy, as well as design, governance, and visualization. Craig has transitioned Medibank from a legacy data management team to a cloud-first data capabilities based on data ops methodology to provide Medibank with the right technology, process, and people to achieve its long-term aspirational objectives. It will be very interesting to hear from Craig in terms of the lessons that Australian health insurance companies have learned in order to thrive and not just survive in the current environment. Welcome you all, the panelists. The structure for the discussion today is that we will have a quick perspective on the topic for the session from each of the panelists, and thereafter we will follow it up with the Q&A from both the live audience as well as discussions from the panelists here. So without much further ado, let me throw the floor open and invite Dr. Darez Ahmed to share his views on the topic for the day.
Thanks, Saurabh. Thanks for a very liberal introduction. And I would like to just mention that you have given some framework for the discussion. What is the readiness of the different players in the health system to adopt health technology, and what is the gap we are trying to bridge? Am I audible, Saurabh?
Yes, Dr. Darez, you are.
Okay. And what is the role medical technologies can play in the whole health system framework? So here, before I go further ahead, I would like to just mention that whatever I will be speaking, it's about a public health perspective. I won't be much speaking about what happens inside the hospital system. So my focus will more be on the public health perspective. See, when you talk about health technology, I'll try to see that what are some problems, what are my practical experience in solving problems using health technology. So when you mentioned I was a commissioner of maternal and child health, we have 1 million deliveries a year in Tamil Nadu, and out of these million deliveries, almost 0.7 million, 70% happens in government system. So in such a system, we were faced with the problem of tracking. The third question I'll come to first, that what are the uses of technology which we can adopt beyond like what is like diagnostics or treatment schedules. Tracking of mothers is one thing which Tamil Nadu, using our mother and child tracking system, try to track the mothers using the technology by linking it to the birth certificate system, that every mother, pregnant mother, gets tracked. What happens in our Indian setting is that the first 2 trimesters, that is the first 6 months of the delivery, happens in the husband's house, and the last trimester, last 3 months, the mother shifts to the where the mother's ancestral house, where she is basically from. So this shift causes us a lot of problem in tracking the mother, high risk mothers, that once she physically shift from one place to another, how do we track these mothers? So we provided like that, it's like it's online available, pregnancy and infant cohort monitoring and evaluation software. That's a mother and child tracking system which we use to track all the mothers and link it to the birth certificate system, so that we know what is the type of high risk mothers which are shifted and where they have shifted, and how the system can respond to the needs of the mother. For example, if a mother with pregnancy induced hypertension shifts to another location, and that location will be alerted, so that they are aware this mother in the final trimester has come, they have to prepare. Or if a mother with some other, like for example, it may be anemia. So this kind of a tracking we have already established, and we were able to now see that what is the geographical movement of the mothers happening, and how the health system can respond to the needs of. So that is one part. When the question number 3 you have shared in the in the mail. And another thing I would like to say is about communicable diseases. So we have another tracking system whereby the, every primary health center, every location, every village will have this fever spikes or a diarrheal episodes. So we have an artificial intelligence mechanism in our public health system whereby we get alerts on exponential rise or some outlier events in diarrheal episodes or fever episodes, so that our public health system can be alerted or our water supply systems can be alerted. So this kind of tracking mechanism and public health surveillance mechanism is already being present in our system to health technology is used to that level. Now I'll come to the Australian connection, which we have been mentioning. So we have been working with Alfred. You are aware of the Alfred in Melbourne. For having a Victorian trauma system is something which we are trying to replicate, and with EAS, Victorian trauma system, and our accident trauma TAC, which the Australian system of accident emergency system TAC, that is Transport Accident Commission. So Tamil Nadu tried to have this trauma system model and the trauma registry which the Victor Alfred has established, and along with that the decision support systems. So in a public health perspective, for example, we have 1,000 ambulance and where to place the ambulance, how the ambulance should be trained, what is the pre-arrival intimation to be given, or everything in one consolidated health technology, health tech system, so that the trauma registry, the endpoint trauma registry, and the rehabilitation. So this has been one of another health tech intervention. Tamil Nadu government had already, we had some interaction, and still I think still going on, and with the Alfred in Australia. And when you talk about doctors and patients acceptance, if you see the pandemic time, we have an e-Sanjeevani. You know, Government of India has established e-Sanjeevani, an online OPD, and almost Tamil Nadu has more than 5 lakh consultations in the last 8 months on this online system. The problem is when you talk about two things, readiness, when you talk about what is the gap public health system is trying to address by using all this technology, that has to be very clearly defined. So that's actually the role of the definition, the role definition of what exactly the system is trying, health system is trying to achieve, and what are the ways we can use. It's not for health technology for technology's sake. We've identified a gap. For example, we had a gap in trauma and emergency care system. We try to bridge that gap. We have a gap in tracking. We try to bridge that gap. We have another gap in communicable disease surveillance. We try to bridge the gap during the pandemic period. The physical activity, physically, we are not, the patient and doctor were not able to meet as freely. So we have established e-Sanjeevani system, and again had more than almost 500,000 consultations in the last 8-9 months, and it is continuing. But here another question I would like to pose before this esteemed panel is that, like, what is the efficacy? What is the studies of, because Australia has a very robust health technology assessment at every level, medical device. So obviously we are also trying, like India is also trying to have a strong health technology assessment mechanism to be established, so that we can see what is the efficacy and what is the per daily, what is the investment, what is the returns on every intervention. So when we talk about health tech, when we talk about interventions, what is the study? What is the efficacy of interventions? Is that actually, if the panel can tell that what are the interventions which have shown real efficacy, and what are the interventions which have shown that it is healthy? You know that there is a huge gap between the provider and the consumer, so there has to be a lot of like checks and balance even in health tech, how the health services are delivered, so that the quality is never compromised and the consumer is always given the proper choice and he has the right to take it or to refuse it. So that will be my introduction. I hope I have been clear. So Saurabh.
Thank you, Dr. Ahmed. Thanks for detailing these aspects out. I am being told that you have a hard stop in another 15 minutes or so. With the permission of the panelist, I would also, use this occasion to quickly, raise a question to you before we let you go. The question that we have here is, you did talk about trauma care, some of the intervention, disease tracking. Those are, quite well developed in Australia, as you rightly pointed out. One more aspect that is quite well developed in the Australian context, based on interactions with various stakeholders, is also disease prevention. Where you are even preventing it from in terms of an occurrence, right? What is your take on that, and is there a role that health technologies or medical technologies can play in preventing the disease in the first place?
Yeah. Saurabh, again, like when you say prevention, okay, if you look at, I will again come back to maternity care. Okay, so a mother in the 10 months can develop so many complications anytime. For example, she can have a pregnancy-induced hypertension, she can have anemia, she can have eclampsia. So many things can happen, go wrong. How do we prevent? First, you have to educate the mother, and it's not easy to communicate to the mother that even a swelling, leg swelling, or somebody she feels swooning or she feels headache itself is an early symptom of having a hypertension. So, how do we educate? So the point is that we are trying to use the gamification. How do you gamify the information and try to pass on the information to the mother in simple and the way she can imbibe? And basically, it's not about the mother alone. It's about educating the husband, educating the in-laws, the family she is, understand that what are the needs so that it can be prevented. The same thing happens to any kind of prevention. For example, a diarrheal outbreak. So prevention is something which primordial prevention itself. If you look at hypertension and diabetes, is two of the 70% of our the disease burden. If you look at our GBD, global burden of disease report, 70% is non-communicable. And if you look at hypertension, it can be prevented at the primordial level, primary level, secondary and tertiary. In the sense that at the all levels of prevention we activate. And primordial prevention is something Tamil Nadu has been strongly advocating by having behavioral change modification and having trying to tackle the using the school health program, Rashtriya Bal Shishya Karyakram, that school health program, how to make children more active and how can you be imbibe these qualities of active life so that obesity can be prevented. So prevention at different levels has been one of the very important aspects, and using technology. Like how do you communicate with the children, mother? How do you, for example, when your mother comes, like using a game to tell her that, like, okay, you have, like in the sense that you have a headache, severe headache and a swelling in leg in the morning, you have to consult a doctor. So, or you have somebody. So the point is that how do you tell her through a game? Gamification of this knowledge is something which you are attempting to do through games. And unless that is the best way to reach because studies have shown that is a way to reach the end, like the mother. I'm talking the maternity because it's something which everybody can equally easily relate to. Same thing applies to communicable or non-communicable prevention.
Excellent. Thank you, Dr. Ahmed. That was really, very eloquently put. And thank you for all the good work that you're doing in this space. It's really interesting, and we're glad to have you as a panelist to share these insights with us.
Excuse me if I have to go because there is a secretary here, so I'll just join back again. Thanks.
Sure. Thank you, Dr. Ahmed. Moving on to the next panelist that we have, in our discussion today. So in the Indian healthcare systems context, the system is dominated by the presence of large hospital chains who have been able to supplement Indian government's hospitals in providing healthcare access at a low cost. And hence, any discussion on commercialization of medical technologies, innovations by Australian startups is incomplete without identifying the collaborative models of working with these institutions. Now, our next speaker does not just has extensive experience of having worked closely with these large hospital chains in India, but he has also been quite active in the healthcare landscape in Australia as well. So it would be very interesting to hear from Mr. Anshul Dayal on any use cases that are relevant in this context. Anshul, over to you. Would be great to hear insights on from you on this on the topic of session.
Sure. Thanks, Orad, and pleasure to meet Craig and Dr. Ammett. So yeah, I think I've got some interesting insights to share. Obviously, I guess as Saurabh mentioned, I think our experience as a startup, we've been lucky enough to have had funding from the New South Wales government in Australia to actually go over to India and made these trips over the course of the last 2 years. And I think the objective for those trips was like typically when, like if you look at the collaboration between two countries, I think what they were exploring was typically they run these delegations, they will go there for a week and they will engage with the stakeholders and partners. But when they come back, the engagement kind of drops off a little bit because, it's, I guess if you look at India as a market, it's, at least from what I've seen and what I've learned is you need a lot of patience to succeed in a market like India. The opportunity is there, no question. It's, whether you're in Healthtech or, agri-tech or clean energy, there's opportunity across many sectors. But I think, the important to understand that it's a very different market dynamic to a lot of the other countries. You have to, kind of plan for at least kind of 2 to 5 years to really succeed commercially. So when we took this trip, I think it was, I think the first conception was that, yes, it's a great big market, lots of, commercial opportunity, huge population. Those are some of the cliches that kind of creep in, huge population, big commercial opportunity. But the reality often is not as straightforward, So the first thing you need to understand is, there are sort of certain different types of pressures in India that, medtech startups in particular need to understand. So I think if I just quickly go back to your the question, I'll try and phrase my answer around the question. So what we saw in India was, if you look at from a rehab sector perspective, which is this sector we actually operating in Australia, the models are very different. Like in Australia, the rehab sector is much more advanced. It's comparable to a lot of the other chronic disease areas that get a lot of funding and attention and qualified professionals that work in the industry. When you go over to India, I think the rehab, at least from the findings, the observations I made and speaking to some of the large hospitals mentioned, the Narayana Group and Ambani Hospital, was the rehab traditionally has not been as seen as a sort of the prime health sort of area. I think it's very much an emerging sort of sector that people, clinicians and health service providers are now really focusing on as one of the health tech sectors. So what we saw was, for example, in Ambani Hospital, I was absolutely blown away by the quality of rehab services that were being offered in a hospital. I mean, that's obviously people who know about the Indian sort of health system, you would understand. Ambani Hospital and the Narayana Group are the top of the crop kind of places. They offer state-of-the-art services, but you do pay a price for it. It's not sort of targeted towards the average person in India. But the services they offered were absolutely state-of-the-art. Like some of the equipment I saw, especially in the rehab division, I met with the head of rehab and he's extremely well respected in India. He's the person who runs the rehab division at Ambani Hospital. But the initial discussion was a little bit skeptical, I think, because I don't think that they ever had the opportunity to have someone, overseas company, turning up at their doorstep and offering potentially a pilot for Australian-based technology to be run in their hospital. But I think once we overcame those initial kind of objections and hurdles, I think I was actually quite surprised by the level of adoption they have, the investment they make in technologies, the knowledge they have, and the administration of services and the therapy delivery was extremely state of the art. So those were the kind of the initial learnings, and I think so. When we came back from the first trip, I think I was actually quite positive that this can actually go somewhere. So I think just kind of summarize. So I think where I see the opportunity for Australian advancements in medical technology that can work in the Indian ecosystem is, I think there is definitely a level of respect for innovation coming out of countries like Australia, US, sort of some of the more advanced countries. So I think there's definitely an opportunity there, and we have seen it in the rehab, specifically in the rehab sector. And I think if you look at I think your second question was the partnership opportunities. So I think those partnership opportunities do exist in the health tech sector. But I think the key factors need to realize and understand is, it's time-based, so you have to be extremely patient. So it's not going to happen in, like a week or a month or a couple of months. It's more like a 12-month exercise to, strike these partnerships and create these opportunities. And I think the third important factor is the cost. And this topic came up repeatedly. Is how much is your technology going to cost? Can people in India actually afford it? So that's something we have to be sort of aware of. If you look at the top level hospitals, I think they can all afford it, like the Ambanis and the Narayana groups, and I think we've met another hospital in Mumbai, the Wockhardt group. So the top tier hospitals, absolutely no question that they can afford. I mean, I saw technologies up to that can cost up to $100,000 being used in some of these hospitals. So the level of adoption in terms of costs is really good. But once you kind of go from the top 10 to the middle tier, that may be a bit challenging to like our technology is probably not going to cost anywhere near that sort of price point. But anything above sort of $10,000-$15,000 does, create a few question marks. So that's something you have to be. And I'll give you another example. I think there was another company that went with us on this 12-month long trade mission. They were developing a genetic testing. Dr. Ben, I think he may actually be in one of the panels on this trade mission, virtual trade mission. So I think it's a really promising technology. They're detecting, the early onset of sort of pediatric conditions using a genomic test. So the first question that came up is how much is going to cost, to test Indian babies for onset of genetic conditions. And I think the price point they were looking at was $700, and straight away it was like, no way, no one can afford this in India. Or very few people, not no one, but very few people can afford it. I think so. It's always it's not to say that not, it's definitely there's enough population there that can afford technologies, but it is a hard sell. So I think it's important to understand that when you go there, like you may have to sort of be a bit more sort of inventive with how you propose your solution to that, or you take a solution to that market. The pricing is one of them, and the adoption is definitely no question that there are enough opportunities there for adoption of Australian medtech technologies, or at least the ones I've seen. But just need to understand those challenges. So, and I think the last question was, I'll just try and rephrase my answer to. So I think where do you see the gap in future of medtech in both countries, and there's a bridge. I think that once again it just really kind of goes back to those initial points I made. I think the opportunities is absolutely there, but you have to just be what will work in Australia may not necessarily work in India because of different pressures. Like there's cost and pricing in India, and I think Craig might actually talk about this a bit more. But the reimbursement aspects of rehab that exist in in Australia don't necessarily exist in India to that level, same level of sophistication, as if that's the word. For example, in Australia, the rehab sector is funded through a combination of channels. We have something called the NDIS, the National Disability Insurance Scheme, which is a government initiative. So that funds a lot of the rehab, or at least from last 10 years, it has been funding a lot of the rehab, the costs and technologies. But I think something like that possibly doesn't exist in India. And then obviously the outpatient services are mostly funded by private health insurers like the Medibanks or the Bupas. I think that definitely exists in India. So there is an aspect of health insurance, but mostly, at least from what I saw, vast majority of people were paying out of pocket. So it was literally just you pay for a service and you get a service. There was no like a reimbursement or at least a well-established reimbursement model, so to speak. So just those are some of the challenges, I think, or the gaps you may see in, where the Australian startups may sort of experience operating in India.
Great. Thank you, Mr. Anshul Dayal. That was quite insightful. And, I briefly mentioned at the start of the session that the views that we are going to hear, because that are going to be quite diverse, because the panelists that we have are from all sectors and spaces of the healthcare ecosystem. While Dr. Ahmed is working with the government on their programs, Anshul has actually worked with the private sector, and you're seeing the disparity that is emerging in kind of thoughts that are coming out, right? In terms of even the ecosystem and the infrastructure that is available across diverse players. The third panelist that we have is going to talk about one more aspect which is becoming extremely important in the Indian context. That's insurance and health insurance. If you would be aware, Australia provides a universal healthcare to its citizens through its universal health insurance scheme, Medicare. Ayushman Bharat is the Indian government's most ambitious health reform program till date. And there are definitely areas where the two countries can learn from each other. And we have an excellent panelist on the session today who works in the sector. And, we would really want to understand from Mr. Rowlands in terms of what are the lessons that Australian health insurance companies have learned, and not just to survive in the space, but actually thrive and grow. And there will be a lot of insights for the insurance companies working in India as they embark on this journey towards having a pervasive insurance to the citizens in India. So would be very keen to hear your thoughts on the topic. Mr. Rowlands, over to you.
Thanks very much, Sharab, and it's a pleasure being on the panel with such esteemed guests. I do feel a little bit like a fraud, certainly when I've listened to Dr. Dayal and Anshul with regard to their responses. So I'll try and do my best to try and keep up with the excellent responses from both of those two gentlemen. I will talk more around health insurance, clearly, and I know that it's only a small sector in India. First of all, as you said, how we survive, and then how we thrive, because private health insurance across the world globally is difficult, it's expensive, we all know that, and obviously that in India has its own issues, never mind in Australia, which is presumed to be quite an affluent country. So for the insurance companies, and Medibank being one of them, typically what you're finding now is for them to survive, we've got, and let's paint the landscape here. There's a diminishing book. So less and less of the Australian population want health insurance because they find it quite costly. So if that's in Australia, I can only imagine what it's going to be like in India, number one. I think number two is when they do want it, and we've already heard about the out-of-pocket experiences already from Anshul. There are lots of out-of-pocket experiences that haven't been good across the sector. So that puts people off taking the insurance anyway. And because of the affordability issues, and again, more prevalent in India than Australia, people are actually going for lower insurance coverage rather than what they require. So you've got all of those. So how do the insurance companies, combat that, for want of a better word? So the first thing you'll see is, and across them, and I'll name a few players here, but they diversify. So Bupa is an example, Global One, run out of the UK, but they have two areas of diversity, really. So for them, they diversify by having aged care homes, first of all. Australia, like many other countries, has a growing aging population, so they feel that is going to be prevalent for them going forward. The second one is if they've also got their own dentistry network. So again, there's no additional cost for them if they're pointing their customers towards their own dentistry outcomes. So their service. Now NIB is another big one, and this is a little bit unfortunate for them at this moment in time, and it's a COVID outcome, but they chose to take QBE's travel insurance book. Now, clearly with COVID, people aren't being able to travel, so that meant that the revenue stream that they were looking at isn't really there. For us at Medibank, we've chosen a different route. So we've chosen not just health insurance, but to offer health services. So as the esteemed gentlemen were talking about, we're thinking more around virtual care. So we're already offering things like palliative care. Now in Australia, it is a paradigm really where although 80% of individuals pass in a hospital, actually the reverse of that is people's emotive opinion, and the fact that they would like to pass at home surrounded by loved ones rather than in a hospital. So there's the first outcome that we look to cater for. The others that are more specific to the conversation today are, we provide the ability to do dialysis at home, we provide the ability to do chemotherapy at home, and more recently we've also started trialing cardiac rehab at home. So they're available. There's virtual healthcare is available for them. Clearly, it's a little bit different than India at the moment, but there's definitely lessons I think India can learn from Australia from that point of view. And that's a growing area for Medibank across the board, regardless of whether it's Australia or India. Also, because of COVID and individuals not being able to get to public hospitals or even private hospitals or even GPs, you've also got this explosion of telehealth outcomes. So in Australia, you've had a lot of virtual appointments that are being made, first of all, before you need to get to actually a face-to-face or more physical one. And that the ability is there, and the ability will be there going forward. If you think about the tech that we've got going forward, of being able to do much of that, on the go going forward, that will happen over some point, be it Australia, be it the US, be it Europe or anywhere else. So they're the changes that we've seen predominantly in the healthcare sector. But what we're also seeing, going back to your earlier questions with regard to the readiness and the mind shift of the doctors towards adoption, it's coming, right? So I would say it was a slow burning, and I'm guessing it's going to be much the same in India, but you're seeing doctors look at the ability to have, there's only an infinite amount of beds for the amount of customers, so and patients. So for hospitals, they want to make sure you've got the right people staying overnight for the right reasons. And if you don't need to stay overnight, can we look at virtual care? This is the dialysis, this is the chemotherapy, this is the rehab. And even for myself, for some of my sporting injuries, when I was a touch younger, as you can tell from the haircut, those will be more for, you want the rehab as soon as possible, and you want to be people up and enjoying their recovery. Two reasons behind that. There's obviously the physical aspect behind that. If you've got people up and you've got them moving, then you're typically going to get a better outcome. But the second one is around health and well-being. So from a mental health perspective, and I know this, from from being stuck in a hospital bed, in a lovely hospital, by the way. That's not a great place to be from a recovery point of view. Regardless, I would much rather recover at home and have a recovery program. And I can tell you that, and I'll give you a couple of examples from an Australian point of view, and I suspect you can translate them to even worse outcomes in India. But 2 years ago, I undertook a heart bypass operation. I had a genetic issue. It was hereditary. And during the course of that, the surgery went really well. But actually, from a rehab point of view, as I was coming out of the hospital, for the public sector, the local hospital to me had a 9-month waiting list for cardiac rehab. I can tell you now, no cardiac rehab individual can wait 9 months for their education and what they need to do better and the things that they need to do to sustain a better lifestyle and a better health and well-being outcome. They just can't. Now, private health sustains that and it helped that. And I was lucky enough, based on my policy, to be able to get free outcomes at a local hospital. But now we can get much more virtual care with regard to those outcomes. And even during my relatively recent visit in India, this is back in October, with TCS, they were looking to trial much more virtual outcomes with regard to testing at home of, I wasn't going to say cost effective, but typically cost effective outcomes to see from the same things that I was looking at for my diagnosis of heart conditions, whether that can be done at home and can be done in a far more cost effective manner in India. That's a great outcome. And during that tour that I undertook, another experience that I found to be fascinating was, and this might relate to Dr. Darrow, so you'll forgive me if I plagiarize this one a little bit, but whilst we were over in Germany, SAP took us to a site visit, and during that site visit, they were showing us breast pumps with sensors on them to confirm how much intake was being provided to the young child, to the baby, and if they were being malnourished, and if there could be early intervention. And that's medtech at its best, right? Because you're looking at really good outcomes from there. Again, regrettably, at this moment in time, these are relatively costly in terms of where we would like them to be, but we're moving in the right direction. So there's a first insight I want to give you with regard to those. I guess when we talk about increasing patient and consumer awareness, yes, I can tell you now, for us, for an Australian, I guess it's going to be no different anywhere else, but net promoter scores go through the roof for individuals who can do rehab and at home outcomes. And the example I give, and you can see this anywhere, it's on YouTube, but there's a Medibank one for a young individual who's got leukemia, and that young individual's recovery was, he's out in an urban in a rural area. It takes a long time for him to get to what you perceive as a local hospital in Australian terms, which is a long drive. Then he's got his chemo, of which clearly he's not feeling at his best after his chemotherapy. And then he's also got a long drive home. And he's got to do that quite frequently. Now imagine the difference if a nurse can come up, can hook you up in your favourite chair, watching Netflix, in his case with his pet dog on his lap to soothe him while he's doing so. And after his chemotherapy, he can go back to his own bed and he can relax there. And then this person will come out on a regular basis. And when he's feeling good, he can get outside. That's a very different outcome. And that's got a very different rehabilitation and recovery outcome for that individual. Now, I'm aware that that's much more difficult to do in India today, but you can start by utilizing insurance outcomes to try and get to those points as well. And we do believe that doctors are much more open to that, and I see them being much more open to that, and the use of data analytics, medtech, virtual care to get the best outcome, because they're also swamped with a tremendous amount of cases, and it needs a number of different outcomes to get to the right outcome for everybody. And included in that, by the way, is education. I mean, if you look at and I'm going to say the UK and Australia, etc., and you see the education around tobacco and tobacco usage. We know in India, tobacco is quite prevalent, and obviously you've got off the back of that lots more cancer type outcomes that you would not want from a lung disease perspective. So there is education on top of everything else that you're looking for as well as an outcome that's going to get you there. And that's not just the hospitals or the states. I'm afraid some of that's got to come from federal budget and from federal spending as well to support these areas. I'll probably stop there so we can get into more questions, particularly as I said, I feel a little bit fraudulent, and I've got two other exceptionally well-versed guests in here, and I'd love to hear some of their views as well.
So, excellent, view, Mr. Rollins, on, the insurance and, what could be done there. Before I move further, I would just like to take, Dr. Ahmed's views on these two topics, right? We heard from Anshul about the cost aspect and, the fact that private sector infrastructure is quite fundamentally different than what you might see in the public sector space. And Craig mentioned about the insurance and penetration of insurance and how that fundamentally changes the kind of service and access that the patient gets. Just wanted to hear your thoughts on the acceptability of insurance currently in the Indian ecosystem, and what you see as potential. Is there a scope for medtech to assist there to increase the penetration in any way? And also on the medical infrastructure availability on the public healthcare space.
Thanks. Two excellent speakers, and I'm really happy that I stayed back and listened to them. And Anshul, I was thinking when you were talking about having this virtual reality for brain stimulation, so I was just thinking that, for example, if you, again, I'll come back to the Victorian example of Transport Accident Commission, how that has taken away the whole insurance model into everybody in trauma care or road traffic accidents. All of you are aware of TAC and how Victoria has done it, VDS has done it. So I would like to say here that there is an assured model of funding. And again, I'll come back to one of the, I'm a very person who has really inspired in the trauma system, Mark Fitzgerald, who is the head of the Alfred, Melbourne. Mark always used to say that absolute budgetary certainty is very critical for any intervention, and especially in trauma care. And we were trying to introduce that part. And when you Anshul say that there is a fund available for rehabilitation, if you look at a trauma care system, once you are that immediate care is over, how the rehab can be provided through a soft, in this app-based rehabilitation system. What are the type of exercise that person should do if you had a femur fracture, or we have already nailed them. So what are the type of, we have tried to do that. I'm not saying that it is successful. What Anshul is attempting is a far tougher and higher area, but we are talking about simple things like once you're discharged, because we also have a bed constraint. Once that patient is discharged from our trauma system, how do we follow him up? What are the exercises you prescribe to him? Okay, he cannot come because he has to get back to his job. So how do we give him a package so that after every 2 weeks you analyze him and say that this is the new exercise, you can just learn through that. We tried that. I'm not saying that it's been very successful. And similarly with the insurance system, I think I just have to go have another meeting lined up. So just that insurance system, as you say, that it's more of a strategic purchasing rather than having an insurance system. As Craig said, in India also, you say that 10% of the people uses 90% of health services. Unless we have some kind of cross subsidy, we cannot really do that. And how is that cross subsidy? Where is it going to come from? Is it SHI, state health insurance, or is it going to be, obviously MSA won't work here? And how do we tackle that? But I feel that the scope of insurance in India will be a strategic purchasing, not beyond that. And with a private and government system competing with each other, that's what my view is, and that's what which in Tamil Nadu, which we have been running an insurance system for the last 10 years. So with that, I will just stop here. But thanks for your great insight, Anshul. I would like to talk to you more on how we can have at a lower level of physical rehabilitation. How do we can, when the patient gets discharged from our facility, how we can help him with a small app-based system.
Yeah,
thank you.
Yeah.
Thank you.
Thanks, Dr. Ahmed. Yeah.
Thank you, Dr. Ahmed. So I'm glad we could get those inputs from Dr. Ahmed in time before he heads out. Anshul, actually, apart from what Dr. Ahmed mentioned, I would just like to add one more question there. Based on what you what you were talking about earlier. Is there a opportunity for the medtech startups or innovative programs from Australia or for that matter anywhere in the world? To look at different business models, right? Because cost will be an important factor. You mentioned about one test which cost more than $700. Now, is there a low cost, large scale kind of business models which could work in an Indian kind of context? And is that scale possible? And have you had a chance to discuss that with any of your peers in the startup space? So apart from that, any thoughts on what Dr. Ahmed mentioned? It would be good to hear from you on these 2 points.
Yeah, I think so. In terms of like the business model, I think it really depends on who your customer is. Like, I mean, if you're aiming towards the hospitals and at least I'm speaking from my sector, obviously, I don't know specifics about the other sectors, but if you look at the comparison, once I go back to my the infant testing solution, which was one of the other companies that they were trying to offer into the Indian market. I think the first thing to understand is who's your customer. I think if you're aiming towards hospitals and the private sector, and some of the large kind of the multidisciplinary kind of hospitals, I think then I would say that the business model that works here can potentially work over there as well. So I think they've got deep enough pockets, if bluntly saying, that they can afford solutions that hospitals in Australia, for example, can afford. So don't think that there is a need for that much of a change in kind of the business model strategy. But if you look at the consumer side of things, I think that's a little more sort of challenging. I think from the price perspective, like obviously, when you look at the kind of the middle class, so to speak, in India, which always becomes a big discussion topic when you look at the Indian market as an opportunity. There's enough people with comparable incomes to the Australian sort of the per capita GDP, so that enough people can afford it. But it's a question of how do we get enough penetration that we can get to those people to promote. I think that really has to come from, at least from what I witnessed. What they look for is, has someone given this product an endorsement from like some respected in the health industry? So that's one strategy. Look for the key opinion leader. Obviously, that applies to any other market, but I think in India that's even more prevalent. To look at, if a neurosurgeon has endorsed a specific type of rehab technology, then I think then you have a much better avenue for penetration to the consumer level, because they listen to the experts in the industry more so than probably in Australia. I think they rely on the sort of the allied health professionals a little bit more. So if the rehab clinician might say, hey, if you use this solution at home, then it's going to be a better option. So that sort of works to some degree. But in India, I think that if a rehab professional suggests something, I think it's not as well respected as the neurosurgeon or someone higher above recommends a type of technology. So I think engaging with the experts in the field over in India is a good option. It's a good strategy, I think. So I think then you can overcome those pricing hurdles much easier. And I think So was that the question? I believe.
Yeah, Anshul. Yeah, that's good to hear. I think.
Can I join in at this one? I'm fascinated by this subject
absolutely,
now. So I'm going to challenge Anshul just a little bit, not too much, but a little bit here, right? So I think there's this kind of godlike status for doctors anyway, right? And this is globally. This isn't just Australia. This isn't England. This isn't India, etc. But typically, when a GP or somebody says something to you, or a doctor, or in my case, a cardiothoracic surgeon, or anybody of that nature, right? You're going to listen to them because you think they're an expert and they know. And in Australia, right, and in probably most of the Western world as well, most people believe that the consultant with the highest cost is the best one. Now, anecdotally, the data is telling us that's not true. This is far from true, right? So even in, I was going to say Western society, people have this belief that there's the doctor, the consultant, etc., does know, and slowly but surely, as Anshul has stated, we're getting to know more and more and getting more and more information around which doctor's best for which outcome, for which surgery, because they could be a jack of all trades and master of none, or they could be a master of specifics rather than others, right? So that's a fascinating situation that's occurring in Australia and elsewhere as well. So, from an insurance point of view, we obviously love seeing that, because that gives more choice and that gives more information out to our customers. So number one. Number two, when you talk about this kind of funding model and people agreeing to it, diabetes is a world issue, but it's obviously an issue in India as much as it is anywhere else. But we all know the testing of sugar levels can be done through sensors and through mobile phones, right? So you can test your sugar level almost any time. So, my view around that would be it would a collective, and as Angel said, there is a number of individuals that are an affluent enough area to be able to support something like that. And if they paid just slightly more, imagine how much they could give to maybe the next level down. It doesn't mean everybody, but it means it's a starting point. So once you've got that recommendation of, this application to resolve for diabetes, so you know that your sugar levels are okay and you're being constantly monitored, what a fantastic outcome for those that can afford it. And if they give a very small amount more on top of that based on that service, could we provide it to another 500 to another 1,000 individuals who potentially couldn't afford it? Brilliant outcome, right, as far as I can see. So those are the kind of areas where, I'd love that advocacy to come from India. And I gave TCS a shameful play earlier. I'm going to give them another one because I'm hoping you guys are going to really enjoy this one. But whilst I was over there, they were trialing sensors in shoes. And as you guys are looking at me going, this is madness, right? But these sensors were effectively looking at people's gait. So after they've had either hip surgery or knee surgery, this was making sure that they're actually walking correctly as part of their gait, and the sensor will pick that information up. Now imagine if you could get a reusable insole at various sizes in a shoe to be able to do that for individuals at scale and cost effective. What a fantastic outcome and innovation in India for Indians that can actually be sold out worldwide, globally at an enterprise level.
Well,
I'll leave that one.
We are coming up with innovative ideas. I think we should probably document this somewhere, from a patent perspective, if that comes up as an innovation in the future as well.
But you cannot steal that one. I think somebody's ahead of us.
So excellent thought there, Craig. And while you are mentioning this, one more thought that I was, it's a question that I have for you is, does data play a role? We did talk about technology, but is data going to play a key role in democratizing this whole, access to technology? So democratized, view of, who is doing what, who has the specialization, in terms of doctors, in terms of effectiveness of certain procedures. Does data have a role to play apart from technology?
Shall I lead off this one?
Yeah, go for it.
Yeah.
Okay. Look, the answer simply is yes, right? But there are a couple of things that we need to be aware of. So obviously regulation and the ability to share confidential information, that's something that we need to overcome, first of all. I think the second one is, and I'm using Australia as the example here, but those health insurers have got a lot of rich data, but they don't like sharing, right? So to get blockchain outcomes, for want of a better word, you need those individuals to share more to get the scale that you need to get the outcomes that you're looking for, and that's really where we want to be. You also want much more federal outcomes as an example of that as well, because in Australia, I see lots of state level outcomes and they're really good, but wouldn't it be great if they were consistent and you could share the best of all of them, and that was provided from a federal outcome? And I'm guessing India is something similar. So there is a little bit of that in there as well. I think the other thing that you've got to say about data is, before you get to any of the innovation and any of the excitement, you need the quality of the data, because we all know garbage in means garbage out, and in this case it could cost lives, right? So that's the other factor. So you need to be really clear with your data and the accuracy around the data that you're using to be able to derive the outcome. So yes, it can be a force for good, but if implemented badly, it could be a force for actually some fairly severe, possibly life-changing outcomes as well. So definitely, and the analytics, as we said, I mean, if I talk about the care programs that we're looking at, and it will be the same worldwide, we look at the customers who are right for chemotherapy at home, are right for dialysis at home, or right for cardiac rehab at home, and we can build up profiles and personas, etc. That's not going to be any different in India, Australia, the US, Germany, or anywhere else. You're still going to be able to build those up. The factor then is how do you roll that out, which I think is where Anshal's grappling at scale, whereas it's a lot more. It's a lot easier to do from a cost basis perspective in Australia than it is in India. That's the real difficulty behind some of the significant issues that are there at the moment. I think it can be done. Can it be done at scale and at the right cost level for it to be something that actually sticks? I think that's the truth for me. Data and analytics can be used in anywhere, in any walk of life, to improve those areas, and in any industry and in any outgoing. I can say that now from every single industry I've been in. Data and analytics can add, providing you do it properly.
I think we are just about running out of time. We have one room for one more question. Anshul, wanted your thoughts on the point that Craig raised on federal support. So maybe some thoughts, because you have worked closely on both sides in India as well as Australia. Do you see a role for government support either in Australia or in the Indian context, which can assist startups like yours in ensuring that the access is widespread and at a lower cost?
So I think I guess I can speak from the Australian perspective. I think I think the government has invested a lot of money into the health tech sector, like specifically to drive innovation. I think the federal government here recently, they've got a medical research future fund, which was I don't know if it was recently launched, but they re-emphasized a lot of the funding, or reallocated a lot of the funding that that's going to drive the medical device innovation in Australia. So I think from an Australian perspective, I don't feel there's lack of support from the government. I think the government's doing enough. I mean, I think but from an Indian perspective, I think it's hard for me to comment, because I actually don't understand what level of support there is in terms of driving startup innovation. But when you look at herein lies the opportunity that if the government's funding so much innovation in Australian medtech, I think that innovation has to expand somewhere. Like the Australian market is not a big market. I mean, you're talking about 24 million people versus billion people. I mean, it's besides the population, it's there is no question that the market opportunity over there is much larger. So there is definitely that there is a role for Australian startups to play in a market like India, because the government is funding innovation, but that innovation cannot sustain itself in a small market like Australia. Like there's a kind of common theme amongst Australian startups that they're very good at research and development, but not very good at commercialization. Because of that reason, the market opportunity is so small. So I think there is that fundamental aspect that if you can drive innovation here and then expand into markets like India, through mutual collaboration, I think that can go a long way in ensuring a lot of this innovation just doesn't go wasted and has actually commercial success.
Excellent. Thanks, Anshul. I think we are just about nearing the end of the session, but really it was excellent to hear your thoughts, both on the role that startups can, play in across both geographies, both India and Australia, an opportunity for, innovative startup like yours. Craig, thank you for sharing insights on the role that insurance companies can play and, how to make it more pervasive and accessible to, all the people. It's more relevant in the Indian context in the current juncture because of the ambitious program that the government is undertaking. But also interesting insights emerging from the role that data can play, in ensuring that the right kind of service and access is provided to the people. And thank you for sharing insights on also the role that government can play in ensuring that healthcare access and benefits are provided to the vast majority of population, and the collaborations that could exist between Indian companies, Australian companies, as well as both the governments. I would like to thank you both, as well as Dr. Ahmed, for taking out time today to be part of this panel. Extremely insightful session, and thank you once again for sharing your views and taking out time for the session today.
Thanks, Saurabh.